able to finish with the first one. Did we finish the introduction to pathology? Were we able to finish it?
Yeah, okay. Sir.
We were able to finish.
Please, a request, please. For the many of us who were not around, can you kindly do a recap for the benefit of the many that were not around?
Well, recap means so I get what you're trying to say. Let me just go to that and quickly see if I can finish and start what I wanted to start with. Okay, so introduction to. Okay, so we started the introduction of pathology, defining pathology, and we said that pathology is the study of disease by scientific methods. We looked at the two arms of pathology, general pathology and the systemic pathology. We defined general pathology as the fact that it deals with the common basic reactions of the cells of the body, general reactions of the cells of the body, right? General reactions of the cells of the body. And then we came to the systemic pathology where we said we are looking at specific and specialized organs reaction to different stimulus. And we defined what disease was. We said that disease was the abnormal variation in structure or function of any part of the body. And then we had four aspects of it: etiology, pathogenesis, morphologic changes, and functional derangements, as well as clinical significance. Then we picked them one after the other, considering the etiology, and for the etiology, he said that we had primary etiology where the cause of the disease is known, and then we had genetic. We had the ones. Hey, Constance Ampofua. Okay, where we have the ones in which the cause is unknown, that is idiopathic, and we moved on to say that the setting of the hospital to be able to treat its clients is actually predominant on being able to know the primary cause of a disease, because it remains the backbone on which diagnosis can be made and then a disease understood as well as treatment developed for the patient or the client. We considered etiology or the cause in two classes or major classes. It can be genetic or acquired. Genetic here, there is less we can do about it, because then the effects will be in the light of chromosomes, DNA, and all that. But for the acquired, the person is born healthy, but when they come in contact with infectious agents, chemicals, physical agents, as well as when there are challenges with nutrition, so nutritional deficiencies also leads to a disease, or it's actually the cause of a disease. We came down to pathogenesis, where we looked at mechanisms, and we said that the mechanisms through which we will have pathological and clinical manifestations will be pathogenesis. We said the pathogenetic mechanisms could be latent or incubational. And when we move from pathogenesis, then we are dealing with morphologic changes. So when after pathogenesis, morphologic changes happen. And I remember I gave an example where I used malaria, and then I made mention of the female Anopheles mosquito and of course made mention of the sporozoids that will be released in between that time and going down to Lukman Bansi. Lukman Bansi. Lukman, on mute. Please on mute. Lukman Bansi, on mute.
Okay, sorry.
Lukman. Lukman Bansi, on mute, please. I want to talk to you. Okay, so we go on. So we made mention of morphologic changes as well, where I told you we have the microscopic and then the macroscopic changes. And I went down to the pathology lab and told you about the macroscopic changes that are observed in the grossing or the cataprum. And the fact that we are not only looking at the organ, as in changes on the organ, but we go down to the cellular level and the tissue level, where at the cellular level, because we cannot see cells with our naked eye, we need to be assisted or aided with a microscope. And I remember making a lot of examples here and there. So after that, we said when morphology is hampered and tempered with, there will be functional derangements and clinical significance. So remember that this is where normal function will be impaired, and if nothing is done about it, in fact, it can even lead to death. The outcome of the disease will be known even from this. So in summary, I said etiology, pathogenesis, morphological changes, as well as clinical features and prognosis of all diseases is what we were talking about. And we actually started looking at the diagnostic techniques that are used in pathology, because in defining pathology, we said that it's the study of diseases using scientific methods. And if we are to use scientific methods, then definitely the scientific methods must be at the base. Right? I think I saw Let me see if I can mute everybody, so that if you want to talk, you just please note that when you come to school to do a top-up, it's not like you are just passing through the school and then automatically the certificate will be given to you because you paid school fees. It doesn't work that way. You have to study and pass. The Zoom lecture is like being in a classroom. You will be assessed and everything. If you don't follow the lectures and you are doing your own thing, and later you don't pass or you don't do well, and you come worrying the lecturer, begging and all that. For somebody like me, I don't go by those begging and those things. Please bear that in mind. I believe that students should be serious, steady. I am seated here just to give you lecture and to explain and get you to understand whatever I am teaching. And people are busy doing other things and not concentrating. And you expect that at the end of the day, you would understand and pass. It doesn't work that way. You are not even respecting us because you are making noise in the classroom, and it's like you are unbothered or unperturbed about it. Please, let's stop that thing. This is the last time I'm making mention of this. Okay. So I've muted everybody. If you want to talk, you click on the raise your hand button, and then I'll unmute from my end. I'll click the unmute button and you unmute from your end also, and then you can talk or ask the question. Okay. So I was talking about the scientific methods and the fact that they are done in labs. They are carried out in labs we have some instruments and machines available, right? We have instruments and machines that are available to carry out these scientific methods. And the idea is that we want to see if we can identify the infectious agent, the insult, or the causative agent. We want to know the etiology of it, but we need to find the causative agent for that. And that is not all. From there, we move on to, after getting to know the causative agent, we even move on to see the changes that have happened with regards to the cells. The changes that have happened with regards to the cells, we report on that. And to be able to see all that and to help the client, you need the labs, you need the labs, you need the labs. And we've actually divided the labs based on the samples. You divided the labs based on the samples. You divided the labs based on the samples. So if samples will be collected from the tissue, if tissue samples will be collected, as in biopsies, then definitely is going to the histopathology lab. When we are taking samples as in cells, single cells, right? Like the cervical smear where we need monolayer cells, here our focus will be on cells. When we are looking at blood and we are interested in blood and the cells of the blood, we are going to the hematopathology or the hematology lab. When we want to culture bacteria and some infectious agents from samples like urine, blood, and all that, then definitely we will be going to the microbiology lab. When we want to relate antigens with antibody interactions, then we are looking at immunohistochemistry. When we want to know what is wrong with the liver cells, metabolic processes and changes, then what we will do is that we take blood sample, keep it in a serum separator, and then send it to the chemical pathology lab to see if the liver is still healthy or it is cirrhosis. If your kidneys are okay, if your kidneys are okay or not. And then when people have mental stress, depressions and all that, they are supposed to, that's also there. But we also have the cytogenetics where we are looking at abnormalities with the chromosomes and the DNAs, where here you have to make use of molecular techniques, like the fluorescent in situ hybridization, like the polymerase chain reaction, where we are even looking at the sequencing and all that, the Western blot and the Southern blot and the Northern blot. And we have autopsy, right? We have autopsy where even when the person is dead, we want to know what killed the person. And a student of mine asked me some time ago that, so in terms of the autopsy, are we looking at macroscopic observation or microscopic? And I told the person that you are looking at both. We are looking at both. We are looking at macroscopic observation because you see, sometimes when people are poisoned, you open their esophagus and you see some discharges there. You see some challenges, you see some discharges which can macroscopically be seen. But we have to take, when we've opened the person up, we have to take samples from their organs, maybe from the kidney, the liver, the spleen, and all that you can think about, and take it to the pathology lab, the histopathology lab, for them to ascertain if the cells are indeed dead or not. Okay, so these were the things that, remember, if you want to ask anything, you click on the raise your hand button and then you can ask your question. So for the histopathological techniques, as I was saying, we take biopsies, tissue samples from living people or living person. We don't take it from a dead person, living person. We take samples from there. And then the nurse has a role to play, especially those that work in the theaters, because we have always had a challenge with the nurses. They take samples. Okay, enjoy your supper. So when they take samples, right, that is the surgeon takes out the tumor or the nodule or whatever it is, the lamp, and then they leave it on their tray for minutes to hours. Then they remember that we have to keep it, and some even forget they keep it in normal saline instead of keeping it in the routine preservative or the routine fixative. The routine fixative is 10% neutral buffered formalin. That's how come sometimes people go to the lab for results, and at the end of the day, they are told that the sample you brought was actually not a good one. The sample you brought was not a good one, so change the sample. Yes. Class rep. Where is the class rep? Click on the raise your hand button, class rep. I want to ask you a question. Okay. Please unmute. Click on the unmute button. Ike, are you there?
Yes, please, yeah, I'm there.
Didn't we go over all these ones?
Yes, we discussed them, but saying some of them were not around, that is why.
No, we don't do that. We don't do that, please. We don't. Where did we get to the last time?
Around the histopathology that you're talking about, that side.
Because I remember we moved from here. We moved from here. We got to around those parts. Yeah. So I'm continuing from there. Okay. I thank you. You can mute, please. And then lower your hand. Because I remember there was a lady that gave a good contribution when we got to this part, and that's how come I remembered it. The histopathology. Okay. So for the cytopathologic techniques, our interest is actually with the cells, right? And for the application of cytopathology, we are screening for early asymptomatic cancers like the cervical cancer that continues to kill a lot of women. Because as I said, it's asymptomatic cancer. There are no symptoms. It doesn't give you any symptom for you to visit the hospital immediately. And in fact, the challenge we have even with cancer is that early detection has been a problem, because the ones that are even symptomatic, the symptoms that will be presented will look exactly like the malaria and the typhoid. So before you meet an oncologist that will ask you to go and do few tests, and they will conclude that this is possibly malignancy or cancer, right? It would have been at the late or the end stages. And that's how come early detections of cancer is very difficult. People die a lot. So imagine even the symptomatic ones tend to elude us or escape us in terms of early detection. How much more the asymptomatic ones, the ones that don't give any sign or symptom. But for the application of cytopathology, the third one is also for the surveillance of patients treated for cancer. And this is to monitor the recurrence of cancer of the urinary tract. People have bladder cancer. And when they have bladder cancer, when they suspect bladder cancer, they ask them to visit the cytopathology lab or cytology lab. They come, they are asked to bring urine. The urine is brought and is spinned. When the spinning is done, the supernatant or the watery surface is poured away, and then we have the deposit. So the deposit, we pour it with a cover glass, and we observe the epithelial cells or the cells that are in there. Sometimes people even prepare smears and allow it to dry in addition. So they have the wet mount and even the dry mount. And then they view the cells. If it is malignant, they will report on it as such, and then they want to see the severity of it. And after that, they will be asked to start treatment. But they might go to the chemotherapy suite or the radiotherapy suite and all that to help with the treatment, start treatment. After a while, they will go for review. And so they will be asked to come to the cytopathology or cytology lab again, and then they will be asked to bring urine again. It will be spinned, deposits will be made, and then the cells will be viewed. If there are improvements, then it means that the drug they are on is helping. But if there isn't any improvement, then it means that the drug is not helping. If there isn't any improvement, then it means that the drug is not helping. If it is getting worse, then that means that they must change the drug. If there is improvement, but not that much, then it means maybe they must increase dosage for that matter. Okay. Now we have the cytopathologic methods, where with the methods we have the fine needle aspiration cytology, FNAC. And these ones, we use our needle and then our syringe under negative pressure. Under negative pressure, where we take samples from there. And for the negative pressure, we expect that the pressure within the tube will be lower than the environmental pressure. The samples are taken, and then we prepare smears from that. And the samples are taken from the noodles, right? They are taken from the lumps and all that. Then we have the exfoliative cytology, where we have the spontaneous shedding of cells into body fluids, sputum, cerebrospinal fluids, urine, and all that. Sputum, cerebrospinal fluids, and all the others. And then we have abrasive cytology, where for abrasive cytology, you have to actually use your tools. You use tools to dislodge cells. These are compact cells. If I stop writing on a screen, you use sharp tools, you use scalpels to dislodge cells from body surfaces, and not only body surfaces like the skin, but then even mucous membranes as well as serous membranes. So this is fine needle aspiration being carried out, and because the noodle is not palpable, they had to be guided by the ultrasound so that they don't punch the voice box or punch the wrong area and then cause even the tumor to spread, especially if it is malignant. Yeah. And when there are also discharges or swellings within the mouth of people, a swab stick can be used to take some cells and the discharge from there. A smear can be prepared, and then a monolayer smear can be prepared. When it is prepared, we put it in a fixative, or we spray what we call cytospray. The cytospray is a mixture of formalin, 10% neutral buffer formalin, or a fixative, and then wax. And mostly we use the cytospray if maybe the cytologist or cytopathologist is not within the region and we have to transport it to the person down in Accra or in Sunyane or in the northern part of Ghana somewhere. Okay. So we have the hematological examination, where here we are looking at the red blood cells, the white blood cells, and the platelets. The red blood cells, the white blood cells, as well as the platelets. The red blood cells, the white blood cells, as well as the platelets. And you see, it's very important as nurses, you know what I'm talking about, and what I'll be adding on. Because when you are at the wards or on your wards, most often than not, they do the complete blood count, the CBC or the full blood count, or even the HB, right, of the clients. And you are to go for the results and bring it to the person, or to staple it in the folder of the person so that the clinician or the doctor can later attend to it. But you should know that when the HB is low, right, instead of waiting for the doctor to come, you can start something. What do I mean by start something? You can actually call the lab, take sample from the patient again or client again, take it to the lab, ask them to see if they can do grouping and cross-matching. Because the HB is very low, especially if it's that low. A full-grown man whose HB is around 5 grams per deciliter needs to be transfused, especially if the person believes in transfusion. If they have relatives, you let the relatives go to the lab and then they test them, and the ones that can donate, they can actually start preparation. And you rush quickly to the consulting room if the clinician or the doctor is not coming to the wards anytime soon. And then you talk to him about it, that this thing is low. Does he think that we should go ahead to do transfusion and all that? When you do that, they find you useful to them. But if you are just in the ward doing nothing and only few things, and at the end of the day, you are on your phone, your confidence in one way or the other is a bit even dampened. And you see, we are in a country where when people are even not confident, we think that they are humble. And it's simply because they don't learn and they are not very innovative and they are not helping on the wards as they are supposed to do. But if you are intelligent, you study, you read around the work you do, your contributions will be valued by the people that work with you. And then they would want to actually recommend you to other people when there is a research on board. Okay. So remember this, that when the HB is low, the possibility of transfusion is very high, right? When you have neutrophils, the WBCs, we can have neutrophils, we can have eosinophils, and we can have lymphocytes as well as even basophils. When you have low neutrophils, we call it neutropenia. When your neutrophils are high, neutrophilia, right? When they are high, it means that when your neutrophils are high, it means that there is a possible bacterial infection. When your lymphocytes are high, there is the possibility of viral infection. When your eosinophils are high, the possibility of allergic reactions are there. When basophils are high, we are looking at parasitic infections. Titus has the hands up. Unmute, Titus. Titus, you can unmute, please. Titus, Yifa, your hand is up. Same. So we have Frederick Auku. Your hand is up. Unmute, Frederick. Frederick, you can unmute and talk. Frederick, unmute.
Hello, sir.
Yes, please.
Please, I want you to throw more light on the hematology with regards to the neutrophils.
I can't hear you, Auku.
Hello, sir. Please, you were saying when the neutrophils are high, there's a bacterial infection. Hello.
Okay, so we don't have much time. Let's go on. Let me mute Auku and then get other people that are. Okay, so David Gasu, your hand is up. You can unmute.
Okay, sir, please can you kindly repeat that aspect when we're talking about the basophils and the neutrophils? I want to hear more about that, right? Thank you.
I was not even done yet. I was not done. So hearing more about it, I've not even moved to the next one. So you should have rather exercise patience and listen. Okay. So I was simply saying that, let me hear that of Georgina before. Okay, so I was simply talking of the fact that the neutrophils, when they are high, then it means there is a bacterial infection. When your lymphocytes are high, then there is the possibility of viral infection. Eosinophils being high, right? It means that there are possibly allergic reactions, and that is not all. When you have your basophils being high, we are looking at parasitic infections also here. That is all there is to know. There can be thrombocytopenia, where your platelets are low. We know that it's not a good thing. Okay. So even the platelets are also important. So in blood, we have the RBCs, the WBCs, and we go down to the platelets. And remember that in situations of anemia, we consider full blood count, and we can prepare a smear, and people can observe the various cells and give the diagnosis of even leukemia to that effect. Asuri, your hand is up on mute. Bertrand.
Yes, please. Please, with the issue of the neutropenia, I am told that once you have extremely neutropenia, it also means infection, not only in the case of neutrophilia, whereby it is excess, but also neutropenia can also be a sign of severe infection too as well. Is that the case?
You said you were told by who?
Well, I learned, yes.
Then go and relearn. Because when you're definitely, then there is a problem with the precursor and in terms of the production of neutrophils, right? Because we more like the neutrophils are like policemen or soldiermen, for which when there is bacterial infection, they are called forth to actually deal with things. And the more they are, then it tells us that yes, indeed, we are expecting to have them in normal ranges. We have a range for it. And when we have them a lot, then if it's lower too, then if it's consistently lower, then it means that there is a problem with regards to the precursors.
Yes, okay. What I learned is that once, let's say, the infection has overwhelmed you, in that case, it can affect the neutrophil count. So in that case, you have the neutrophil count extremely low instead of being high.
The problem is not with the overwhelming, because there are people that are overwhelmed and they still produce more neutrophils. Is that not so?
Okay.
So that's it. So if we are going down to the root cause, it's not, because if it is the case where all the time people have low neutrophil counts when they are overwhelmed, then that's another issue. That means that it's like, let me give you an example. It's like the barracks, and then we have armed robbers somewhere, and then the armed robbers are increasing in number, and we have a lot of soldier men in the barracks. Why would we not bring the soldier men? The moment we have less soldier men there, then so the problem is the fact that we don't have enough recruitment, and there is a problem with the recruitment. Okay. So I have Titus Yifa again. Unmute Titus. Titus, your thing. Go ahead.
Thank you, sir. It was my network that was why I couldn't do it. Hello, sir.
Hello, we are listening, Titus. We are listening.
Back on what you were saying. You said the word like this one, we noticed that as a man, your HB is 5 point something gram per deciliter, that we should, as a very intelligent and then hardworking, you should quickly take the sample to the lab for cross-examination, or the cross-matching, before you seek doctor's advice. Sometimes we have fight between the nurses and the doctors in the ward on that case, on these cases. So how do we do that? You will do certain things so that you can fast track things for the patient. And doctor will come and ask you, who gave you the orders? Where did you see the orders before you start doing this? You see?
So
I think everything is defined in our job description.
What I was talking about was not you. I wasn't saying that you should transfuse the person. And in fact, even when you've seen that the HB is low, the best you can do is to talk to the doctor, show it to him, and tell him that you are taking pragmatic steps to take samples to the lab if it's okay, so that things can be done. Do you get it? I'm not saying that discard the wisdom or the intelligence of the clinician or the doctor and then do what you want. That's not what I'm preaching here, or that's not what I'm propagating here. But, and as you see, sometimes it also has to do with the kind of doctor you are working with. If you have built a good rapport with the doctor, definitely they know that what you are doing is to ease even the job. But if you have not built any rapport with the person, and like you don't, if you've done that over the period where maybe now a case comes up, the HB is low, you go to him and tell him that, oh, this and this and this and that. In situations where he is not available or around, when you call him, whilst he's even on his way, those steps can be taken to help, where grouping, cross-matching can be done, awaiting his orders. Do you get it?
Okay. Yes, sir.
That's what I'm trying to say. Because the life of the person matters. If we are to wait for him to come and then he's out of town, maybe going to the next 2 towns to do a surgery there or something, and now he's not even done with his thing to come, will we let the person lie down like that and later die? No.
No, it's unprofessional.
So obviously, steps must be taken, discussions must go on, so that here the ultimate is the client or the patient, and the patient needs to be saved, regardless of the cadre you find yourself or the profession you find yourself in.
Okay.
But as I said, respect must be given.
Respect
must be given. Consult him first. Let him be aware
sure.
what is being done. Okay. So thank you very much. Let's go.
Okay. Thank you, sir.
So we have the immunohistochemistry. For immunohistochemistry, it is actually antigen-antibody interaction, and these ones, they are done in tissues. And we would want to identify or know the type of disease, and even the severity of the disease. We can even use immunohistochemistry to identify infectious agents as well. So this is how it is. We know that in immunology, our bodies, when there are antigens, right, this allow the production of antibodies from the plasma cells. And these antibodies will come directly to bind to the antigens, So there can be cross-infection, but the type of antigen that actually ensure the production of the antibodies will come directly, splicing and not binding to the other antigens available. It will go to the particular antigen that called for its production from the plasma cells. And so based on this, what happens is that we decided to replicate this outside the body in tissue. So if there is a disease we suspect, we will have a biopsy, and then we will pour our antibodies on the tissue. When the antibody is able to bind to it, we incubate it in a fluorochrome, that's fluorescent dye, or even enzymes, and then DAB, so that it gives us a brownish color to tell us that, yes, it is positive, and indeed the antigen for this particular disease is present in the tissue. So in the situations of even progesterone receptors, estrogen receptors, and HER2 in breast cancer, all of those ones are also very important. We use immunohistochemistry to know the severity of the cancer, okay, and to even classify it as well. Then we have microbiological examination, where here we are looking at parasitology and then going down to bacteriology, where we take samples to culture and do sensitivity with our antibiotics, right? And then the parasitology, 2 samples are taken, and then we view for parasites. And we can have parasites like the Strongyloides tecuralis, the H. nana, the Ascaris umbricoides, and the Schistosoma japonicum, and all those ones. Okay. So this is what I was talking about. Yeah. So we move on to the biochemical examination or the chemical pathology. And then for chemical pathology, here we are looking at metabolic disturbances, like I said earlier, where if somebody decides to abuse alcohol, we know what will happen. At the end of the day, the liver will have a problem. The liver can be cirrhosed, right? When somebody is infected with hepatitis B, we know the outcome, as in the late stages or late ends of it. We know that there will be a problem with the liver as well. We know that when challenges nowadays that people are drinking, doing dangerous combos of energy drink with alcohol. We know that when a person decides to live that kind of life, very soon their kidneys will pack up. Yeah, so in the chemical pathology unit, they do the liver function test, they do the renal function test, they even consider the cholesterol levels of people, and even there are hormonal acids that are even run at the place. Okay, then we have the cytogenetic factors here, where for cytogenetics, we are looking at chromosomal abnormalities even in somatic cells. So we are looking at aberrations, we are looking at translocations, inversions, deletions, and all that. And the technique for that will be the molecular technique, where we have the fluorescent in situ hybridization shortened as FISH. We have the southern blot, we have the northern blot, the western blot, the PCR, the agarose gel electrophoresis, and the sequencings that can be done. And we have autopsy, where we can do for clinical purposes. A person dies and want to know what killed the person, clinical purpose in the clinic. But then if there are disputes as to who killed and what killed the person and is brought to the court, then we are looking at autopsy for forensic purposes. Autopsy for forensic purposes. So I have some picture here. The old way is here, and now we have the new way here. The old way is there. Now we have the new way. Okay. Okay, I'm checking the chat box. I saw plenty of messages I have to check. Okay, so Rita is saying that, sir, please, at our end, at accident and emergency, and we are giving the might to prescribe and request an investigation after you examine the patient. Wonderful, that's good. Somebody is asking, sir, please, is grafting an abrasive cytology? No, please, it is not. Because in grafting, you have to do tissue compatibility testing before. It is not. Here, in the abrasive cytology, we are just dislodging cells to find infectious agents or causative agents. Okay. So we move on. So we go on. So for the causes of diseases, we have two. We have environmental factor and then the genetic factor, or even both. For the environmental factor, we have physical agents, chemical agents, nutritional deficiencies and excesses, infections and infestations, immunological factors, psychogenic factors, physical agents, chemical agents, nutritional deficiencies and excesses, infections and infestations, immunological factors, psychogenic factors. For the physical agent, we are looking at physical energy that is applied in excess to the body and can end up with a damage to the cells. And can end up with damage to the cells, right? So we have trauma, we have radiation, we have extreme temperatures, and we have electric power, and electric power as well. Okay. So note that car accidents fall under physical agent, contusions, when people stab people, and all that. Any physical energy that is applied in excess that causes damage to the cell falls under physical agent. Then we have chemical agents. And these ones span from the paracetamols we take, even the drugs we take, down to the chemicals we are exposed to at our workplaces, and also down to the pomades that people use, the bleaching creams and all that, some of which ends up destroying the melanocytes and all that. Yes, and even goes down to the ones that are applied when the women want to go and then wash their hair and dress their hair and all that. And I don't understand why a very small child at the age of like about 5 years, still with their brain developing, and the mother wants to perm the hair and plait the hair and put ribbons in there. And they wonder why the child is not thinking correctly. You've exposed the child, you even the older person, look at the pain you go through when they have to put you under the dryer and all that. People spend monies every 2 weeks about 400 or 200 or 300 cedis on making the hair. The sad thing is that when the child is now ready for senior high, they go and cut off the hair. So what was the waste of the investment? And then not only the waste of the investment, the harm you would have caused to the cells of the brain as well as the head. So all these ones, and please know that there are some of the chemicals that are direct acting. Some are direct acting. When they are exposed to the body, immediately it causes damage. There are others too. They are indirect acting. They have to accumulate to a certain threshold and be able to cause problems. Accumulate to a certain threshold before it will be able to cause problems. Before it will be able to cause problems. Okay. So please note that. So I have this picture here. Look at the face of this child. Just exposure to a chemical. And that's how bad it is. And when a person abuses alcohol, it being cirrhosis will not be immediately. It will be a gradual thing. So you compound it and it gets to a point where your liver says that I can't do this anymore. And then it remains like this. So this is a healthy liver and this is a cirrhosed liver. This is a healthy liver. This is a cirrhosed liver. Then we have nutritional deficiencies. Somebody is asking, what is the difference between clinical and biological death? You are rushing, please. Mr. Isifu Koso will talk about it. Just wait. Somebody has given me the name. Stephanie, Retouch Cream. Thank you, Steph. So for me, I have never understood why a young child, and then you have to pass the child through such harm. And at the end of the day, when they are going to senior high, they go and barb the hair. So what is that wrong investment? You have wasted your time, disturbed the cells of the brain of the child as well. And some of these children are put under hot dryers and they are crying. And all in the name of the mother trying to just, I don't know, try to make their friends know that they have a baby girl and they have permed the hair and putting some funny ribbon on the head of the child. And they are not thinking of the health of the child. Okay, so we go on. Esther has the hand up. Let me see what she has to say. Esther, please, you can unmute.
Okay, thank you. Please, I want to ask, so we've identified the physical and then the chemical. If someone gets burns, where will you classify it under? Or it depends on what caused the burn.
Actually, to be physical, please. Burns, physical.
Physical.
But just,
even if it's an acid or something.
If it's an acid, then it will fall under chemical. So you see the name here has to do with, if the composition of what caused it has to do with chemicals, then it will fall under the chemical. That's why we made mention of cyanide, direct acting also.
Okay, thank you, sir.
Esther, are we okay?
Yes, please. Yes, please. Thank you.
Okay. Always welcome, please. Blessed. Your hand is up.
Sir, please. I'm also at the TB unit. And when they come, they do two types of tests. That's the skin test and the blood. So at this stage, where will you classify these two things?
Where will I classify what?
At this stage, well, will it be a physical or would the skin test be under the physical?
No, here we are looking at the cause of the disease. Oh,
okay, sir.
Yeah, so always welcome, please.
Okay, thank you.
Okay, so we go on. So for the nutritional deficiencies and excesses, I always summarize it this way for my students. Every class I've taught, I summarize it this way for them. What the rich people get to eat and eat in excess causes a disease. What the poor needs to eat and they don't get to eat also leads to a disease. So what it means is that what you can afford, when you abuse it, it brings a disease. What you need and you can't afford, because the body needs it, if you're not able to afford or provide it, it also leads to a disease of a sort. So we know of the obesities, the type 2 the diabetes, we know of the high blood pressures, the heart diseases, coronary diseases, and all that are associated with excess intake of certain nutrients. But in terms of the deficiencies, I have an example here of iron deficiency, where you have the restless leg syndrome, frequent headaches, increased sensitivity to cold, brittle nails, hair loss, depression, shortness of breath, fatigue and tiredness. All these symptoms and signs are as a result of iron deficiency. Okay. Then we move on, still on the course. We have immunological factors. Our immune cells are supposed to be able to fight infectious agents and microorganisms and parasites. However, the immune system can act abnormally, and that can lead to a disease. So in terms of hypersensitivity, we are looking at exaggerated activities of the immune cells. So it's like there is, in the situation of asthmatic clients or asthma, where they have this bronchial asthma just from a pollen, a harmless pollen, or even a perfume. The IgE will kick in and they will start reacting and having this wheezing sound and all that. And it's because hypersensitivity, the immune cells, they are overworking. And the effect will not be something good. It will lead to a disease. So that is a picture of hypersensitivity. And the next one will be autoimmunity and then immunodeficiency. There are people that are not able to produce certain immunoglobulins or certain immune cells, which are needed to deal with certain infections and certain diseases of the body. If that becomes the case, then it means that when it comes to that particular infectious agent, the person will not be able to deal with it because they don't have, or they are not able to produce those immune cells. Then we have autoimmunity, and autoimmunity is simply the hypersensitivity against self-antigens, where your immune cells fight against your other cells, right? They fight against the cells of your skin, fight against the cells of your kidney, your liver, and all that. And in this situation, we are looking at systemic lupus erythematosus as an example. Rheumatoid arthritis is part of it. Discoid lupus erythematosus is also part of it. Even in the situation of type 1 diabetes, which is caused by the autoimmune destruction of our beta cells. Yeah, so that is how it is. I thought I saw the hand of somebody. I thought I saw the hand of somebody. Okay. So Priscilla, unmute Priscilla.
Okay, sir. Please, I wanted you to throw more light on how iron deficiency may cause depression. I'm a little bit confused with that.
That, please, because of our time and what we have to do, we can't throw more light. What we need to tell you is what we've told you. If you are interested in further, you read further, right? I gave reading materials out. You check the reading materials and they have all those details in there.
Okay, thank you.
Always welcome. So I think I can see Ketura's hand. Ketura, unmute.
Sir, please, I wanted to ask if dermatitis, is it under autoimmunity or hypersensitivity?
It will be hypersensitivity.
Okay, thank you.
Always welcome. So we go on. I think I can see Saeed, your hand is up.
Please, I'm allergic to bread and wheat, anything made of wheat. When I take it, I get reaction. So I don't know where it will be classified.
Definitely, you'll be under hypersensitivity, sir.
Okay, thank you.
Always welcome. So we move on. So remember, autoimmunity is hypersensitivity against self-antigens. So we have psychogenic factors here, and here we are looking at mental stress. Mental stress. We are looking at mental stress, and then depressions and all that. Depressions and all that you can think about. And you know, for this mental stress, for most Africans, or let me say most Ghanaians, the reason why you have some would have rather, is when they lose somebody they truly love or is dear to them. Some years ago, I used to give lectures to some diploma class, and then a lady shared with me when the father died, because of how close they were and all that, she ended up depressed and all that. But for most of the depression cases we've had, and the mental stresses or mental stress cases we've had, it is only when people do wrong investment. They decide to use their money to take care of a lady they have not married at the senior high level and even in nursing diploma. And the lady will end up meeting a doctor, and then they end up not marrying the person. And before they know it, they are now in a whole lot of wahala. And then all that, those challenges. And they will have mental stress and all that. If you do that, if you are not married to the person and you are doing that, please note, it can go both ways. When you fall into depression or you get into any challenge, it's your own cup of tea for doing that. And for the ladies who have not been married and you have turned yourself into chefs and cooking acheke and abenkwine and light soup and whatever, using your own money, the day they will not marry you, remember that I told you of psychogenic factors, mental stress and depression. Maybe you have to go and see your psychologist and your psychiatrist to help you in that light. When you do wrong investment, mostly for the African, that's when they go into all this mental stress, where they will need psychologists and then even psychiatrists to help them. So be careful where you are investing, because if you invest wrongly, okay, we go on. Then we have the genetic factors where you have aberration, like I told you earlier on, in the situations of Down syndrome, right? Down syndrome. even for the subtle change, congenital malformations associated with Down syndrome, and even the subtle changes we find with single amino acids substitutions in the situation of hemoglobin S, which will give rise to sickle cell anemia. Okay. So now let's consider the cause. Remember, this time it's not the CAUSE, but the COURSE of disease. The COURSE of the disease. And this one is quite similar to what we discussed earlier on. That is the 4 aspects. So we have exposure, we have the biological onset, clinical onset, permanent damage, death, and in between the exposure, where you have the causative agent, and then the biological onset is where you have the latent period or the incubational period. That's the pathogenesis. Yes. So note, the natural cause of the disease in the absence of any intervention is called the natural history of the disease. When a person comes to the consulting room or to the hospital, and then they tell you, well, I'm not feeling well, the interrogations will go on, the complaints will be written down. The clinician will end up asking, have you taken some drugs or any drug? Most of the time, the people will say no. Some will even lie, thinking that when they say yes, they will not be given drug. And understand that, I don't know if the people don't know that Tabia and all those local things they take, they fall under interventions. Some of them will enema, if it's a child, enema the child, give them something to drink. Before they even come to the hospital, they would have gone to the pharmacy shop and then bought some drugs and all that. We have interventions. Those are also interventions. It goes even beyond drugs as well. So remember that the natural cause of disease in the absence of any intervention is the natural history of the disease. And it includes exposure to various risk factors, latent period between biological onset of the disease. We have the biological onset of disease. This marks the initiation of the disease process without signs and symptoms. And remember, we also have the incubation period, which refers to viable period of time without any obvious sign or symptoms. And then we have the clinical, and for the clinical, it presents with signs and symptoms as well. If nothing is done about it, even at the clinical level, no intervention is introduced, what will happen is that there will be permanent damage to some cells. If the cells are few, things can be considered, it can be redeemable. But if the damage is that wide, which takes more like about half or 3/4 or the full organ, if all the cells of the organ, the tissues and everything in there are all affected and they are all having permanent damage, that means function of the organ will cease. And that will lead to death. Note that the natural recovery, which is recovery without any intervention, can occur. But I'll always add this, that natural recovery can occur without intervention, because there are some churches that don't believe in taking drugs or any form of drugs in this regard. But remember that if that's the case, before any infectious agent or before any infection or disease, make sure that your immune system is strong. You eat well, you exercise, you don't joke with your vegetables and your fruits and all that, so that your immune cells are strong and you are healthy. Either than that, when you are maybe immunocompromised or immunodeficient in one way or the other, and you are infected and you tell yourself, me, I don't take interventions, you might end up dying. I've seen people die in that order. And let me say that in the hospital, there are various interventions that can be administered, dependent on the disease we are dealing with. So now let's look at the outcome and consequence of disease. Outcome and then the consequence of disease. Outcome and consequence of disease. Okay. So we go on. So in terms of the outcome and then the consequences of the disease, we can have resolution can occur leaving no sequela. And here, resolution here means that the person can get healthy, become okay, right, without any traces of the infectious agent. Without any traces of the infectious agent. And then the next one is disease can settle down, but then there are still the infectious agents there. And this time it gives them the opportunity to now metamorphose or transform to cause a more severe disease or a different disease. So it's either there will be complete resolution or the disease settles down, the person stops taking the drug, and there are still infectious agents within the system that can cause serious havoc. Okay. And if we just leave it like that, we leave the disease like that, it might end up in death. It might result in death. It might result in death. Okay. It might result in death. It might result in death. Okay. So let's move on. Since we ended on death, let's continue with death. There are two forms of death. The gentleman that asked about the difference between clinical death and biological death or biologic death. Now we've got into that place. So we have clinical death, and for clinical death is defined as the period of respiratory, circulatory, and brain arrest, during which initiation of resuscitation can lead to recovery. And this is the reason why when you certify somebody clinically dead, when the doctor or the clinician certifies somebody clinically dead and the person comes back to life, you cannot sue the doctor, because the definition of clinical death means that there can be the initiation of resuscitation and possibly lead to recovery. Remember that clinical death begins with either the last agonal inhalation or the last cardiac contraction. And I've been teaching this course for a while, and some students have shared with me their experiences, some of which are very interesting. Yeah. I think the last time some midwifery class I taught, they shared with me a situation where a child was certified clinically dead, and they were waiting for the mortuary attendants and all that. By the time the guys delayed and got there, the child that had been certified clinically dead was now breathing and then was kicking. Like, was out of the womb. So the baby was like, the hands were moving and crying. But this child was certified an hour ago clinically dead. So remember, clinical death is the reversible transmission between life and then death. Biologic death, sorry. Between life and then biological death or biologic death. What are the signs of clinical death? What are the signs of clinical death? One, patient is without pulse and is completely unresponsive to pain. Patient is without pulse, right, and is completely unresponsive to pain. The pupils are widely dilated. Some reflex reactions to external stimulation are preserved. There is recovery that can occur with resuscitation. So I can see the hand of Gideon Kwame or say up. Please unmute and talk, Gideon.
Please, I wanted to ask, with the explanation to clinical death, does it mean when a patient, when a doctor says the patient is clinically dead, we should do resuscitation so that the patient will come back to life? Because I'm confused a bit.
We didn't say that That is the absolute case. We said there is the possibility of resuscitation for which there can be recovery. Did you get it?
Yeah, so would it be necessary for us to do that? Try to resuscitate?
Yeah, to see if, but then you see, the final authority in the hospital and in our setting in Ghana here is the doctor. Is that not so?
Yes, please.
So if Kwame, the doctor is not interested in that, will you be the one to go and say you want to try?
Okay, please take it.
But you see, if we work, the problem is we don't work as a team. If we actually had a teamwork, right, where now the doctor understands that the nurse has a role to play and the nurse is not a danderhead or is not a dullard. So, and they have something to say and they can suggest. The person can say, oh, can we see if in this case resuscitation is possible and it's required? Kwame, do you get it?
Yes, please.
And
so
then
is it the reason why most of the time before that there's a need for resuscitation?
That's why.
Please, thank you.
Always welcome. And Kwame, there are a lot of examples like that where people just are killed even by the mortuary attendants. But immediately they come to carry the person, maybe within some, because we don't do autopsy on the bodies immediately. They are left there, and then maybe the next day the pathologist will come around to do all that. But in the course of they being taken to the morgue, people end up sometimes. Well, let me leave it at that. Okay, so I can see more hands there. Isaac Frimpong, your hand is up. Please make your questions brief. We don't have a lot of time on our hands. Isaac Frimpong, your hand is up.
Okay, so I want to ask about the clinical death. Yeah, I have on mute. Please, can you hear me?
Sure, we can.
Yeah, I want to ask about the clinical death. You said the definition was if there is cessation of respiration, circulation, and then brain arrest. So I want to know the full meaning of that brain arrest. Is it that your brain is not functioning, so now you are dead, or it's kind of function, but you are still dead?
So the issue is when it's more of a simple word of the partial function or not more of a complete function of the entire brain. Do you get it? It's not like the whole brain stem and all the other aspects are gone. It is in the biological death that we have the entire brain gone. In this situation, not the entire brain is gone. I don't know if Frimpong got what I said. Okay. So we have Gifty Amma also there. Gifty.
Yeah, hello, sir.
Yes, please.
Okay, please, I wanted to ask about like the cause of the disease and as well as the death. Let's say a patient came to the ward, so the triage with malaria, show signs and symptoms of malaria. You did RDT, it was negative. You went further to do BF for MPs, there was no MP seen, okay? But the child is showing signs and symptoms of malaria with chills, bitterness in the mouth, fever. And the doctor said because the lab investigation says there is no MPs, you didn't give any anti-malaria or saying you let them go home. So they came back with cerebral malaria, a complicated version of the malaria, and eventually the child died. So I'm asking that with this, when the signs and symptoms are there and the lab investigations are saying there is no MPs, can you still administer the medication for them?
Gifty, it's a very brilliant question. In fact, I like your question.
Thank you.
It's a very, very good question. You see, we have a big problem in this country called Ghana, and even in African countries as well. The reason is because you ask yourself, how well is your lab stocked with the requisite instruments and machines? Recently, I went to do an assessment for some students, and I had to visit some hospitals, top-notch hospitals. And when I entered certain places, they had to take me around, and then I entered their lab. I entered the lab, and I was just glad. In fact, Gifty, for the malaria, for the BF for MPs, you have a full system machine that actually does the counting and everything.
Okay.
And this machine is actually serviced from time to time. You can't compare that to maybe some lab in somewhere where the people there are not even properly trained and they are not even certified and they are not professionals. If you base your argument and your treatment sometimes on that, you might end up killing your client. If the signs are glaring and they are so showing, you have to go ahead. We've had people that have saved people's lives with that, even though we know that now they say that if the lab is saying otherwise, don't treat. But this is a situation like what you are saying, where now the child comes back with a more severe case and the child died. What would have gone wrong if at the end of the day we administered the drugs to the child and then we saved the life of the child? So we have a big problem. The problem here is the fact that let me say that's how come the experienced people on the field, they will, even though they respect the lab and everything, when there is a challenge with the results and they think that what I am looking at and what the lab is saying now is different, they will go ahead because what they are seeing is what is important. They will go ahead and save the life of the person. Gifty, I hope you're okay.
Yes, please. Okay. So please, and the last question, and this one, a child was unresponsive, and we tried reviving the child, and then we gave adrenaline. Okay, so we did everything, resuscitation, but it was unsuccessful, to no avail, and the doctor certified the death. But the child was still having heartbeats, but we realized it was from the adrenaline. So with the doctor certifying the death, but there was still heart sounds or heartbeats, do we say it is the right way, or we should rather wait for the heartbeats to stop before the doctor certifies the death?
I don't know why the clinician was so much in a hurry, but sometimes based on what I told you, we have what we look out for. Some doctors will not tick all the boxes. They just look at 3 or 4, and then knowing that they had given adrenaline and possibly can be the reason why you have the pumping happening, then they decide that, well, if all the others, there is the brain arrest, there is a challenge with all the others we made mention of, then there will be no need of waiting.
Okay.
Some decide to go. But for those that still feel like, Charlie, maybe I have 2 or 3 still working, it's only one that looks like it's checked in terms of clinical death, they will take their time to see what will happen.
Okay, thank you very much.
Okay. Gifty, thank you for good questions.
Thank you.
So we go on to Bukari Abdul Wadud. You can please unmute. Be quick about your questions. They should be nice questions. But will be,
Sir, good evening. Please, mine is more of a contribution to.
Let's go.
A friend asked about the CPR and then the clinical death. The doctor declared a patient clinically dead. Usually, I would say the doctor doesn't voice out that this person is clinically dead. They only start the chest compression or the CPR when there's no pulse and other things. So until those ones are not there, then he initiates the CPR or the chest compressions. It is when those things all are now failed, he can say this person is dead. So I think that they usually they mention out is the biological death they mention. Clinically, they don't mention it, but they just look at what the patient is going through, and then
are you saying no, Bukari? Wait, Bukari. Are you saying that the doctors mentioned the biologic death or biological death?
No, I'm saying that it's only when the person they have initiated the person doesn't have pulse, the person doesn't respond to any stimuli in the environment. There are dilated pupils. Then they will initiate the CPR or the chest compressions. They don't say this person is there, so let's start chest compressions. It's only when they see those things, then they'll say, okay, let's initiate to see if we can bring the person back from the clinical death. Usually they don't say, oh, this person is dead, let's do this. They start to do them before they even announce that the person is dead.
So they will not say that, but they will do just like you're saying, they will do all that. But let me say this. What they write in there is clinical death. I hope you know that.
Yes, please.
Because biologic death is actually by the pathologist. Biological death is by the pathologist. Because you see, in the biological death, we go down to the cellular level. When the cell goes through the necrotic death, where we have the challenge with the membrane integrity, and then the nucleus undergoes the shrinkage, fragmentation, and dissolution by release of the enzymes. That means that the tissue, when you view it under the microscope, you will not find nucleus there. Then we say that there is biological death. Okay. I think there are other hands too. Yes, please. Don't worry, let me finish the lecture and I'll get back to you. Okay. So we have Ajua Pinamine. Your hand is up. Please, the questions, people, a lot of hands. Ajua Pinamine.
Hello, sir.
Yes.
Sorry, I thought I had lowered my hand. I wanted to make a contribution on the issue of malaria. So we realized that sometimes when patients present themselves to the hospitals, they have already gone to buy over-the-counter medications. And some of these patients actually work to the pharmacies to buy drugs for malaria and all that. And when they realize that they are not doing well, then they come to the hospitals. So when that happens, because they have already taken prophylaxis of some sort or treatment of some sort, you do the RDT or show negative, and then you may even have the MPs recording no parasites seen, because the parasites are already being fought. So I wanted to add, and then you said it, so I'm reiterating that a very good physician will go ahead and then give the medication anyway, because it's not doing harm to the patient in any way. So a very good physician will go ahead and give the anti-malaria anyway to avoid any further complications. Thank you.
Okay. Thank you, Ajua. Your contributions are valued. Rita Shabra, I hope I didn't murder your name. Rita, your hand is up, please.
Please, I wanted to, hello, sir. I wanted to add up to what Gifty was saying. I wanted to tell Gifty that when a case like that comes to their end, they have to go on and treat, because at our facility is a referral center, and they may refer a case to us with the investigation being done, RDT will be negative, HB will be 3, but when they come to our place, we have to do recheck of the investigation again. You might see that the patient came with HB of 3, but after doing our own investigation, you will see that the HB will be around 9 or something. So human beings are not to be trusted. So when a case like that comes, you have to go on and do your treatment to save the patient. Thank you.
Always welcome. That's a good one. So you see why I believe in integrity, because sometimes the people living at the other end that are supposed to do what they are supposed to do, because they felt it was time for them to close, they wouldn't do it. They just, I heard of this thing, which for me, I felt it was very unprofessional. Somebody went to the lab, and then because the guys were closing and they had put off the machine, they came out, look at the face of the man, examined the man, and just went in and wrote no parasites, claiming that if you look at the face of the man, he's healthy, the person is not sick, the person is okay and all that. And that was bad. I'll come back to the questions. I still see hands up and all that. But please let me finish what I have here, because I have to finish today this slide, so that next week we can go on to the other ones. You've actually dragged my time. I wanted to finish and start my next topic. But okay, so let's go. I'll come back to you with the questions. So I was talking about the clinical death, and I think we've done justice to it with your wonderful contributions all over. Yeah, with your wonderful contributions. So that is basically it. So for the signs of clinical death, your patient is without pulse and is completely unresponsive to pain. The pupils are widely dilated. Some reflex reactions to external stimulation are preserved, and we have recovery can occur with resuscitation. So just like we're talking about the CPR and whatever. So we have the biological death. It's known as the sure sign of death. It is known as the sure sign of death. So some people are talking about slice and all that. Please note, if you have not joined, I can see that we are 700 plus here. If you've not been included on our WhatsApp page, the pathology, let them include you. If you are too many, I think we can consider a different platform which can help all of us. A different platform. Telegram can be for all of us if the numbers are too many, so that the slides can be resent there, and then information pertaining to whatever it is can also be given there to help everybody. I don't want situations where it will be time for exam and people are lost as to whatever it is that is going on. Yeah, so please let us take that into consideration. So class rep, do due diligence. Okay. So we move on from there. It sets in after clinical death and is an irreversible state of cellular destruction. Irreversible state of cellular destruction. It manifests with irreversible cessation of circulatory and respiratory functions, or irreversible cessation of all functions of the entire brain, including the brain stem, the entire brain. So remember here, it manifests with irreversible cessation of circulatory and respiratory function, or irreversible cessation of all functions of the entire brain, including brain stem. Please remember that. So I have an assignment for you. I wanted you to see this. What are the diagnostic modalities used by the pathologist? Describe the cause of the disease. What are the purposes of tissue fixation? And then what is pathogenesis? And I want 1 page for each question. 1 page for each question. 1 page for each question. We are typing, and I'll give you, it will be sent actually to me. An email will be given before next week. It must be ready and then sent like that. Okay. So okay. So I think now let me look at a few questions. Abukari Abdallah, you're gonna mute. Abukari Abdallah, you can please unmute.
Hello. Hello, sir. Hello.
Hello, Abukari.
Yeah, please, I was trying to find out, a situation whereby you take a patient's sample, especially the children, take a sample to the lab, like the HB and others. Then they will give you a result that shows that there's nothing wrong. The HB is okay. But you change the name and send it back again with the same sample, and then a different result will be given to you. So I want to know what are some of the reasons for that.
Abukari, the problem is the hematology analyzer they are using. It's probably because maybe they do not do calibration, and in the mornings also they do not do their controls for it to pass. So it gives different results for even the same sample. or the person that actually was doing the test didn't allow the swelling of the sample to ensure even distribution of the cells. That could also be the issue. So two things are happening here. Here, these ones, they are not like the BF for MPs where they have to use microscope, somebody to sit by. They subject it to a hematology analyzer. So if the analyzer is working well, the controls passed and everything, there shouldn't be, even if there will be differences, it will be just maybe if it was 6.1, the next one might be 6.2 or maybe 5.9. Oh, sorry, 6.0 or 6.1, maybe 6.2, but not like maybe 3, and then the next one was like 10. Or like what our friend, one of the people that contributed were saying, is that for their place is a referral center, and they bring samples which clients whose HBs are 3, they redo and it's 9. Something is wrong with the hematology analyzer. It must be checked. Maybe servicing has not been done for a long time on it. It must be done. Abakari, I hope you are okay.
Yeah, thank you very much.
Always welcome, please. So we have Bukari, Abdul Wadud. Your hand is up. You can unmute.
Okay, sir. I needed some clarification on the assignment. You did mention describe the cause of disease. And then the cause there is the COURSE. I don't know whether it's a spelling mistake or you want.
Were you following the lecture?
Yes.
You didn't see cause of disease. COU, not CA.
So I just needed to clarify whether it is this.
No, I'm also asking you a question that you didn't see COURSE anywhere in the lecture.
I did saw it, sir.
You did?
Yes.
Okay. Okay, so we have Redeemer. Unmute, Redeemer.
Good evening, sir. Sorry, to add up, I think I want to use this as a scenario. It happened at my facility.
That's good.
I work, yes, please. So a child was brought in at night around 8 p.m. My facility where I do my locum, the lab doesn't work at night. So when the child came, the child was exhibiting signs of malaria. So I was with my colleague. Then they set a line for the child. Then she was about to administer artesunate, in which the doctor told her to. So before she was about to administer the artesunate, I told her not to give the artesunate first. She should take the sample down before she gives the artesunate. And she told me the labs is not working. So the lab will come the following day. The following day, they can take the sample. And I told her that no, you can take the sample in the EDTA tube and keep it in the fridge, because the immediate sample will give you the right or accurate lab results, rather than you giving the medication for it to start working before the following day you take the sample. If you do that, it's going to alter the results. So it became an argument, 1 or 2, and I let go. But for me, I took the sample before the artesunate was given. So the following day, we were called to ask us, they asked us the reason why a little argument sparked out at the emergency. And I explained everything. Then my boss told me to excuse. Then she had to educate her on the reason why I said that. So I think to add up to some what our colleague said, immediate sample taking is important before giving medications. If after giving medications, the prescriber or the doctor tells you that take another sample and let's run another lab to see if there's improvement, that's fine. But I think immediate sample taking will also help for a better diagnosis and easy positive prognosis for a patient. Thank you.
Sometimes, you see, Redeemer, I don't understand people. Why would there even be an argument in the first place? Were you taking a sample? Was
Yes.
it a he or a she? I'm talking of the person that was arguing with you.
It's a she, a female, of course.
Why were you taking her sample or something?
Yes, I was taking the child's sample down.
No, you don't get my question. Were you taking her sample, the nurse's sample?
No, please.
So what was her problem?
She
Sometimes people just want to be overly bossy at the workplace. If whatever the person is doing, they are responsible for it. If at the end of the day to not lead to the death of the person, but help the person, it's just samples that are being taken here. Or sample is being taken. So what's wrong? Anyway, but we thank God that we have people like you that can at least convince and then be able to help clients out there. Thank you.
Welcome, sir.
So we move on. We have Joshua. Joshua, you can unmute, please.
Sir, please, the assignment, is it an individual assignment or is group assignment, and how is it going to be done, please? Thank you.
Mr. Joshua, have I grouped you?
No, please, but before you leave the line, please.
I should group you before I leave.
No, I said I want this clarification before maybe the class comes to an end.
If I don't say something, don't assume. I said assignment. I gave it out to the class. I didn't say group assignment. If I had written group assignment or into bracket, then it is a group assignment. So you submit it individually.
Thank you, sir.
Always welcome, sir. Okay. So we have Ayamba, Samira, Jemima. You can please unmute. Ayamba, unmute quickly. We want to go.
Okay. Good evening, sir.
Good evening, Ayamba.
Please, mine is a contribution to our sister who said they are at a referral center. Anytime came, they received a client with the HB of 3. But when they checked, the HB was 9. I've ever referred a client. We referred with a very low HB, but they got to the facility there, they did their HB, and they said they had 9. So instead of allowing the client in the facility to monitor and check if the fault was in their machines or ours, they discharged them and asked them to go home. But the client just went straight to the house. And the following morning, as at 4 a.m., they came back to the facility with the child, very weak. We asked why you didn't go when we referred you or what. The client said they went and they said the HB was okay, and they asked them to go home. So when we rechecked the HB, it even went lower than we checked earlier. So we still referred them and said they should go. And went with them. So it was really a sad time for picking it up, but not to really observe and not just following the machines and their results. Sometimes we need to observe the clients, not to quickly discharge and say, our instrument says this. So that's my little I have to add to us.
The way you are responding, I'm sure it might be your facility. Maybe later we'll
No. It was the other way around. In fact, it pained us how we lost that child. It really pained us.
Okay.
Yes.
Next time, I'm sure. Why your facility, there is less you can do to help such clients.
In fact.
Why you don't transfuse
over here is just
you don't have a blood bank there?
No, we just can check. It's a health center and we can only check for HB.
Okay.
Then MPs. So refer to a higher level facility, and that was what happened.
Okay, I get it. Don't worry. We hope that next time something better can be done. Okay. Thank you. Let's look at the next person.
Okay.
Atambiri Augustina, on mute. Hey, the hands are plenty, Papa. Augustina Atambiri, you can.
Good evening, sir.
Evening,
Hello.
please. I'm here, please.
Yes, sir. Okay. So my own is a question. A brother was admitted in the hospital. He was knocked down by stroke. So he was in the hospital for a week. And then the day of the discharge, the doctor discharged him and he came home. Less than an hour, he died. So they called us when we rushed and got there. Then the wife was telling us that the doctor said he was probably going to die and he wasn't sure, so they should go home. So me, I don't understand the pathology, the type of pathology diagnosis that the doctor used in knowing that he was going to die, so they should go home.
Well, that one, you see, I wouldn't also be able to explain. You said a person had stroke.
Yes. Anyway, they said they did the CT scan. They said they did a CT scan.
So maybe knowing the severity of the situation, that's how come maybe he knew this one, the person would not survive. It's just like in terms of even malignancies or cancers, where we are able to consider the grade and the stage. When they look at the grade and stage of it, they can tell you with prognosis that this person might not live up to 2 months or 3 months. So maybe after the CT scan, these evaluations, you got to know that this particular person, looking at the level of stroke, the severity of it, the person might die. And that's how come they die.
Okay.
Yeah.
Thank you, sir. So it was based.
So next person, Cecilia Frimpoma. Quickly. Cecilia Frimpoma on mute. Okay, since Cecilia Frimpoma is not, let's consider Nuhu Shawana. Nuhu Shawana, you can please unmute. Okay, let me go to the chat. Ebenezer Ankuma, you can unmute.
Hello, sir.
Yes, Ebenezer.
Yes, with the lab, with the referral centers, sometimes I just want to make a contribution here. Those who normally have a CHIPS compound and those small facilities, sometimes they use the machine, the HB detector. You see, you have a small machine that when you can pick the sample and yes, please. That one normally when you check and use the microscope or with those with the bigger facilities use their own to do it. Sometimes it differs. There has never been a way. Sometimes the value is very huge, but sometimes I'll urge all of you to when you see the HB. There was a situation. The HB was like 8 point something. I'm at the children's ward. The HB was 8 point something. But looking at the assess, when I assess the child, you can see from the feet and the fingers, it looks pale. So compiling the HB and the physical assessment of the child doesn't look. So I was on the view that we should. The child was very weak. We've given all IV artemisinin, we've given whatever we have to do. So the child is very weak. So I suggest to the clinicians that we should transfuse. And they didn't, throw away with my idea. They transfuse and the child gets better. So sometimes as nurses, we should be able to assess the patient. No, we shouldn't go straightly with the labs too. Sometimes when you go with the lab, sometimes you can make mistakes as well. So I urge all of you to also look at that for all of us.
Okay, thank you. I think that
Sir, Cecilia, I'm back. Can I speak? Can I ask the question?
Yes, you can.
Okay, so thank you for the opportunity. Please, I'm at the children's ward. My question is concerned with transfusion. After transfusing patients, maybe patient come with after the full blood count, the WBC were around 16. Then after transfusion, we have done all the patient is on antibiotics already. Then we transfuse with the low HB, maybe around 7 or 6. Then after transfusion, post-transfusion HB will come, then WBC will rather go high. So I wanted to know, is there any something that is going on or what may cause something like that to happen? It can even shoot to 32 or 30, thereabout.
But I hope you know that who is speaking right now? Who is speaking right now? Hello? Hello? Hello, Candy? Okay, so I think I lost her again. So let me see. Badu OWUSU Andrews, you can unmute and talk quickly. My time is even up, so we have to, I'll be you.
Okay, so I wanted to ask a question. When you were speaking, you made mention of it that with biological death, it's only the pathologist who confirms that a patient is what biologically dead, and the doctor also confirms patient being clinically dead. And I wanted to ask that. So after the doctor has confirmed patient as clinically dead, do you also have to wait for the pathologist so that he too comes to make his investigations in order to confirm patients?
The body will be sent to them at the mortuary, the morgue. That's where they will take the body. So that's when they go and do the autopsy or the postmortems and take samples and they go and view the slides and then bring their reports. Because the only time you are able to collect cells and look at the state of the cells is when they've done their autopsies.
Oh, all right. Okay. Thank you very much.
You. Always welcome. So we have who again? Rita Shabra. On mute. I think you might be the last person. The time is gone.
I wanted to add up to what
after the lecture, call me. Class rep, after the lecture, call me.
Sir, please, I wanted to add up to what my sister was asking about the HB. I was saying that for her speaking, she made mention of being at a cheap compound. But me, I'm at a district hospital. So when you refer to our place, it's not what you've written on the referral that we have to go straight and treat the patient. We have to do our own investigation and other things before we start our treatment, because you did your own treatment there and you couldn't succeed. That's why you refer the patient to our end. So we have to go through again and start our treatment. So when you bring an HB of 3, that doesn't mean because you've referred the patient to our end, we have to start transfusion. No, we have to do recheck of the HB and C at our end before we do the transfusion. And for my case, we didn't discharge the patient. Thank you.
Okay. It's all right. So I think that we would end here. I think we have just 3 people, so let's take them. Frimpong, Yabua Joshua. Gift, mute yourself. Mensa Richard, you can unmute. Let's take him, and then that will be all. And then Priscilla.
Okay, so here is a scenario. A patient was admitted to the medical ward with an HB of 2.2 grams per deciliter. Then we the nurses during that time, the doctor wasn't around. So upon communicating with we took a sample, sent it to the lab, cross-matching grouping. Then he asked us to transfuse 4 liters of whole blood. So later on, when he came around, after review, we realized that the patient was had blood in urine. And they diagnosed her of thrombocytopenia also. But later, the doctor was just asking us to, like, the patient's relatives to get platelet concentrate, 4 units, which we were not getting in the whole region from the blood banks. So there, I want to know if the whole blood can still be given to the patient in place of the platelet concentrate until we get the platelet concentrate, sir.
No.
So in this regard, we have to initially consider the HB, because in giving blood, you are not only giving platelets. How you know you are giving red blood cells as well as the white blood cells, right? And then the platelets also come in here. In saving the individual, we can decide to transfuse the person, but we have to sit down and look at the math of the state of the other cells before we bring in the platelets. If we could get platelets, fine. If we can't, saving the person's life is also important. So you can decide to then go straight away to transfuse to aid the person. But it wouldn't be that much. If I got your question clearly then. Okay. So I think that it's okay. We've had enough of the questions, and myself, I'm even tired. Please remember, you see, today I took time, answered all your questions. I would say about 90%. There will be a day we have a lot to do. I might not be answering a lot of questions or listening or taking a lot of contributions in that order. When that happens, please bear with me. It's not intentional. Class rep after lectures, see me. Class rep after lectures, please see me. Okay. Okay, so thank you very much for coming to class. See you next week. Bye-bye.